Okay, this has been an extremely long day, and I'm sure that you have made notes of things that you want to comment or bring up for discussion. Um, Inga, do you want first to say something about this system? Sorry, the our common.
Consortium.
Yes.
Last year, after listening all to the conversations and thinking about the whole issues of sustainability, a group of us got together and we were thinking that it could be very nice to have a forum, some sort of a consortium in which all of these different people combine forces to share skills and training, but also because I'm very concerned about sustainability and succession planning for not just my own program but for others, to think about finding resources to ensure that these programs can grow and be sustainable in the future. So we were talking about that as to whether we should have some sort of umbrella organization and whether the EFC&I could facilitate that in some way. And then there's obviously the question of, because I wasn't really linked up to your organization, as to how your organization also could facilitate this. Because I think if we have separate programs looking for resources to do things separately, we're not as strong as if we work together and see how we fit together and how we can support growth in all of our programs. So that was what we thought about, and so I would like to ask Petra to think about that.
Absolutely, and I might, tell you a little bit how we got around to sort of create this European Association of Developmental Care. And that really came out of the need that we think that in our professional lives as pediatricians and as neonatologists, as care personnel within this field, we need to know more about development and base our action on the basis of improving and maintaining normal development. And so we felt that NIDCAP was, for example, one training area where that was done in a very good way, but it was done on a focused area and it wasn't spanning the entire phase of development. And so when I talked around me and what I had experienced in my time in the US, I actually felt that Europe was quite advanced in thinking about development. We have, of course, very prominent developmental psychologists that Jean Piaget and a lot of people who thought about infant development and brought about a little bit like Silke now has done for the newborns, the awareness of the child as a specific human being in our society that in the initial century, in the last centuries, weren't put so much emphasis on. So I think in exactly that role, I felt it was the time to build this association that should be a platform to disseminate awareness of what's happening and what should we do to maintain or improve development of children, of newborns, of preemies, and maybe even fetuses in the maternal fetal world. And it wasn't to be a program, but it was to be a platform of exchange. And we've started very small with just having meetings where we clearly addressed professionals that came from different disciplines. So it's not just MDs, it's not just nurses, it's not just psychologists, it's not just PTs. It's the whole range of people that are working or have an interest with the developing child. And of course, the parents' view on child development, we couldn't be thinking about development without including the family. So This is a platform. Right now it's a website, and it's waited to be animated by whoever has something to say. And the big task will be, how do we control what goes on there? And that, of course, is sometimes a bit difficult. But on the other hand, I find what we're doing right now, that we work together with groups that we know. We have all a history of knowing each other for quite a while, so we can actually cross-foster the diffusion of our ideas. And I very much liked Inga's approach in trying to elaborate better knowledge about development for the parents. And that, I think, could be something that we could have a major impact already, to sort of say, if parents come and ask the care team and they know more than the care team will be very motivated to learn more about it. Because what we see in our units is often that we have a little bit of a hard time to get the right motivation there to really maintain a regular observation of our newborns and preterm babies in the unit. Because we all think, well, we know them, right? We don't need to observe them even in a more specific way. But as soon as a parent is present, the nurses often are a bit, how do I say, and the physicians also surprised when very distinct observations come that the care team haven't actually done themselves yet. And so that's where we have to get to.
And you think that a training consortium would fit in with your program as well? That could be a part of this kind of organization. Yeah. What would you?
Different training programs.
Yes, definitely. I think it's very important to make clear that even if both Inga and I are affiliated to the NITCAP Federation International, also Silk actually, and you also have some as well. This is not something for just NITCAP. We don't want to have it like we'd like to have it totally separate from one specific program. It's very, very important because we want to have it inclusive of all initiatives from other programs as well.
What do you think, Silke?
Well, I think it's important. Well, we have heard a lot of different training programs today. For us as parents, is challenging which one is the one which is maximum helpful for my child, or is it similar than the others? I guess normal parents are overwhelmed with this kind of information. So, and what is helpful in the end for them, I guess. And what for us is very challenging when we see in hospitals, this nurse or doctor is treating my child in this way, and this and this doctor or nurse is treating my child in another way. And so, and then this nurse explains to me how I should treat my baby, and then in the other shift, another nurse is coming and do totally the opposite. And so this is, I guess, something where parents are totally struggling, and where we need a more, say, red line, where we can trust the health professionals. And for us, it's challenging to see which one is the one which is needed for, I say, whole Europe or for one country. And that's challenging, I guess, for us. But the consortium, that depends how it is organized. Is it one organization who is taking care of all of the things? Is there a competition between the organizations or trainings? Or how can this be financed? Because when I hear some of these trainings cost 5,000 to 10,000 euros per person, how should this financed in Hungary? How should this financed in Bulgaria?
That was exactly the reason why Inga took this initiative of Family and Infant Neurobehavioral Education Program. You might comment a little bit more and also explain the independency of programs.
Could I ask Milica to talk about it?
Yes, please.
They have used it in Serbia, and I think Serbia is an example of a country that's...
Well, maybe I can share our experience with you today. As probably some of you know, we started NITCAP Education and Implementation in 2010. up to now we have one NIDCAP graduate, another one is near term, but a little bit late because of maternity leave, and the third one gave up after a year. All this process was not financed by any governmental educational source. It was sponsored, actually, and we were always trying very hard to sponsor and to raise funds for such an education. That was the reason, and we are very big neonatal unit. Silke and Inga know, as they visited our hospital, we are the biggest neonatal center in Serbia. We have a capacity of 160 beds for the babies. We had near 300 employed people. 250 are medical professionals, nurses and medical doctors, and you can imagine how difficult it can be to educate so many people. So when we learned from Inga about practical skills and FINE program, we decided to start this program. We enrolled in 2012, Inga, I think, or 13.
2013.
2013,
I think,
6 students, 6 trainees into this program in attempt to strengthen the level of developmental care, to keep it at least on the achieved level. And it showed up to be very good, as all the students found it quite not demanding. It was not any delay in their practice. All of them finished the training. So we have now at least one nurse at every ward to take care on developmental supportive care on the level that this program offers. Our idea is to continue with FINE program education, and at the same time we see this as an opportunity for those students or graduates to have better insights and to decide whether they'd like to enroll to NIDCAP training. Do they have bigger interest, or they want to continue further with more advanced training? And it gives also us an opportunity to make a very good decision where to invest and where to go further. Anyhow, we are willing to continue both with NIDCAP and FINE program, because having in mind the number of staff and the size of a hospital, we think that this approach is appropriate for us. Thank you.
Yeah, thank you very much. Would your aim be? How big proportion of your staff would you aim to go through the FINE program? What do you think would be feasible?
Well, our possibilities up to now are maybe that we can enroll 6 people per year now for this year, and then we will decide what we are going to do in the future.
Can I just add something? Because the other thing about this is they're now beginning to work with centres in other countries that have nothing. So you're starting to work with other neighbouring countries, and considering the history of the region, this is just amazing. And so they're becoming a resource for several other countries around them who are beginning to ask questions, and they're going to run workshops and creating. So they're becoming a hub for their area, which is also something that I'm very interested in seeing happen.
Yeah, that's very interesting. The region has learned about us, and in 2010, nobody knew what is it all about, but now they're very interested and they're addressing to us.
Zach, you had a comment?
Can I comment to that? Because I think this is exactly what, for example, the EADCare would like to see in their next meeting. So I would encourage you to evaluate according to some research standards that we will try to make available on this website of EADCare, and then expose your results to your peers from different programs to discuss what are your results. Are you satisfied with your results? Are there ways to improve the way you have implemented this and the improvement in outcome of the children? Or are there other parts that you need to abandon because really you've made no difference, or you've even worsened your outcome? So the EADC meetings would be one place where this kind of reflective results could be put to an audience that is very knowledgeable in the area. That would be one of the ideas.
Yeah, thank you. Zach?
I'm going back to that. It's very encouraging to hear the work that you're doing in Serbia and also having an influence in the region. I'm going back to the topic about developing a training consortium, and I'm looking at 4 people here who have some connection with NIDCAP. And so I would make a recommendation that if you develop the idea of a training consortium, that you have a larger circle and that you include people who are not affiliated with NIDCAP. So back to Serbia, in Hungary, we're looking at developing the work with close collaboration. There may be a lot that we could learn across the ideas and the boundaries that come from something other than just an affiliation with NIDCAP and this new program.
You are invited right away.
Yeah, but
it would be fantastic.
I would also like others to,
yes, sure,
to
but I mean,
step
this
forward
is
or be invited.
The intention of this
whatever.
meeting
Right.
is exactly that. The intention of this meeting is to include all different programs and in the future as well.
And that was exactly the idea of the consortium, that it isn't one focused on one thing, because we can learn so much from being part of a group with lots of other programs.
Thank you.
Thank you.
Yeah.
Thank you. My name is Velma Libbe. I'm from South Africa. I got a lot of insight today in what we do and how we actually align with what's done in other places, and for me that's good to hear. There are a few things I would like to comment on, and especially talking about a consortium for training. I think it's a big need that we have in South Africa, but then in the African continent. And I think the touch points, especially like with Serbia and Hungary, we don't have the resources. And where we started in South Africa is everybody is looking at NIDCAP and thinking NIDCAP is the gold standard, and that's all we can do, so people need to go and get NIDCAP training. So, no, you can't send somebody over to America for 6 months or 2 years to get NIDCAP training and come back and then try and start a nursery. That's just not viable. Also, it's very expensive to get trainers to us. So we were in the same situation of what do we do then? So we went back and looked at what does the literature say, what is developmental care about, not only the programs, but what's the basis of developmental care. And from that, started and tried to design our own program. And listening to what the speakers say, especially Inga, we're doing similar things and looking at a similar route. Now, we have a few challenges. Some of them being that neonatal training for nurses have been stopped in South Africa. Our regulatory body is not recognizing it anymore, so the universities are not presenting it. That's for the last, I think, 5 years, if I'm not mistaken. So it's included either in adult ICU or in child care or a little bit in midwifery, but now we're separate. So that is one big problem. The other one is that our care, both the care and the follow-up, is an outlying area. So we don't have staff that's trained, and we can't train them in a single area. It's really rural, 4 hours drive, no roads, those kind of things. But these people still need to provide the right care for these babies because they are born at 500 grams and then they lie in a clinic environment. Also, we have a lot of allied health professionals interested in coming into the NICUs, but there's no training for them to get into the NICUs. They can do pediatric training, but there's no neonatal training. So at the end of the day, even the training that we do present is still too expensive. And then I talk about $30 for a 4-day training, which includes lunch and notes and everything, but that on a nursing salary is still too expensive. So we have a few challenges, but there's a few things happening as well. Why this long story? I would like to look at collaboration, and there I think it's one of the difficult things is how do you collaborate because we're not in Europe, we're in Africa. So in my view, I would like to see a mentoring or a buddy or something like that, to not to duplicate, but maybe to look at our environment and learn from other areas and see what we've already done and how one can build on that. So that's just a few thoughts I would love to share. Thanks.
Thank you for this meeting, because it's always very interesting. And I think the same language we could have all together, the parents and the professional, is that we need to implement actions that are research-based and family-centered. That are the two main points we need to be very, very focused on. And now we know that intervention has positive impact. That is demonstrated. So we need now to understand what could be the best dose. Because if we want to decrease the dose, it's like for antibiotics. Do you need to treat 5 days, 10 days, 1 day? And for developmental care, we need also to understand what could be the minimal dose to get an effect. And that could be very interesting to do as research. And the other point is that there is a lot of new paper on implementation science, because you need to demonstrate the positive impact of a program, but you need also to be sure that when you implement the program, the implementation is a success. And if no, there could be a negative impact because the process is not fully implemented. So we need to do more research, as we said 10 years ago, but not to demonstrate the impact, to understand how it's better to do the developmental care with the resource we could have in each country.
Yeah, thank you for a very important comment. The analogy with the doses of medicine, do you think there is a risk of getting a resistance development if it's too low dose?
No, but we know that there is resistance. Some physicians are very resistant. So they could support minimal implementation without any impact. Only saying, oh, we are doing developmental care, and that's enough. We don't need to go further on what could be really family-centered care. Do we want that the parents are partners? There is a very nice paper from the Canadian team in Montreal last month, and they explain the difference between what is professional-based care, what is family-centered care, and what is the parents are as partners. And that is really the goal we need to have. So the process is important, and the process in the Netherlands is very interesting to understand how it's always going on, and that is to improve the quality of care. But the dose, what is the dose? How many hours parents in an ICU? What is the best level of light? What is the best level of noise? What is the best duration of breastfeeding? We need to reflect and to work on that also.
I think Lisa.
My name is Liisa Lehtonen from Turku, Finland, and we have been running this close collaboration with parents program. And from our experience, one aspect to this question of dose is how many staff members you need to train to change the culture And we have set our goal in changing the care culture of a unit. And from our experience, you need to have both medical and nursing staff on board. It's not enough to have either. And from our experience, you need to train practically the full staff, everybody. And it's better to train everybody to a certain level than some people to expert level, because changing the culture depends on the weakest link in your unit. So it should be very broad, maybe with low dose, but broadly. That's our experience. And I think we have gathered that experience from 6 different units now.
Charlotte Casper from Toulouse. I have just a question. Wouldn't it be helpful to that these programs would be a part of the education of NICU nurses and neonatologists, and I mean that we have kind of a ground to stand on, and then of course we have to implement in the units, but to have some basic knowledge about observations and relationships with patients in this area.
I guess it's working. Yeah, it
so
was exactly
more collaboration with universities and, and education programs.
It was exactly what I wanted to say. So it's perfect. Yeah, this is exactly what I said yesterday where we met, that I think it's important not to have trainings and trainings and trainings, and then some of them can do it and some not. So in a long-term or middle-time perspective, we have to change the curriculum of education and also the training system, that every year or every second year they need a repeat to learn this, or the new research details. Most of the research is in English. In most of the European countries, they are not speaking or they can't read the research data. So we need to influence this in the beginning. So when a nurse wants to be a neonatal nurse, when a neonatologist wants to be a neonatologist, then they have to learn to understand that parents have to be involved, and why is this the brain important, that parents are there, and breastfeeding and so on. So this is where we start, and the old nurse and the old doctors who have not received now this education, they need to be trained, and we need a basic training, and so that we can start then with the next step and next step. But when we start here with just 5 people of 100 staff members, then we never receive this. This virus is not going to the whole team, and this is a rethinking, and we have to fight for it. And as I heard the South African example, I was just thinking, why you're not standing up, why you are not fighting with your parents and organize a petition to rechange this law. This is possible. We did this in a couple of projects also here in Europe. Stand up for it. It's your job. It's your work you're doing. You have a lot of opinions and maybe results why it is important to have neonatal nurse and why you have to have enough nurses for them, for the babies, because the outcome will be bad in the future. It costs a lot of money if they're not doing. You have hundreds and thousands of parents in your country. Let them stand up. And this is what you can do. If you use parents only as donations for your research, you will not get them. You have to catch them with their needs when they have them as partners. This is what the French organization is doing now very well. SOS Prima is organizing now with the societies and with the neonatologist projects together. Then they work with you together. And this is when you're a real partner, and we are now real partner of the societies, then we fight together. And this is possible. It needs time. It's not going from today to tomorrow, but stand up for what you want.
And also I think your topic expert group of training and education will definitely deal with what Charlotte Casper from Toulouse brought up. So it will be taken care of. Yeah.
Just have a question. I'm Jean-Charles Picot from France, from Lyon, France. Just have a question for Silke Madder, because I was wondering just if you, how do you think your action is fantastic, and I really find it very useful. And then, how do you think it will go back to hospital directors. You know, you say, well, parents, not visitors, but my hospital director is just making parents paying to stay in the with their car in the hospital, so they cannot stay for the whole day long, and this type of things, which are very simple, but it's just an example. But the way babies and parents are considered in our hospital is very important, and we need your help, because nowadays with the crisis and the budget problems, then they don't hear us anymore. It's very difficult. So my question is, how are you going to make it? You're going through a law in Europe at the European level to that it can go back to the each country by the way of a law about prematurity or thing like that. About how do you feel your action will be on the practice? Will act on the practice at the end, because it's very impressive the way you move very rapidly. But at the end, we really need you, and we really need you to help our directors to hear about what we are talking about.
Yeah, you're absolutely right. It's not only, this is why we also started, first of all, not to have a paper, you have it online, so that everybody, parents, politicians, journalists, everybody has access to it, so that it's not something secret. That was the first thing what we want to do. Parallel to this project where we develop the standards, of course, parallel, we start with awareness campaigning. This is the Make a Difference thing, that we really put pressure on each single hospital. So in your example, your aim maybe is welcoming parents 24 hours, 7 days a week. Of course, your director will say, are you crazy? And of course, but then you need your national or regional parent organization to start with this. You need politicians who are standing behind you. And of course, there will be a toolkit on advocacy and on policy work, because it's not something what you have next year or when in 5 years the standard of NICU design is ready. I fight for NICU design now 10 years in Germany. And first start now to rebuild and connect Bubu and the team here in Karolinska to see it. They get hundreds of visits in the next years, I think, but this is something what it starts now, that they rethink, and it needs time. And this is the same with education and training. All of these 11 groups will need time, but you have to start, and you have to knock on the doors of your director step by step. But you also have to work parallel on political level and also on awareness. If you always be silent, if you not start with projects, if you not work with your parent organization, then you will not change it. If you not present them results why it is important, of course, then you will never receive it. It is a fight, and you will not be the best friend in the end of your director. That's also clear.
My question is linked to what we have been saying. Is I didn't see in your working groups the group on economics. Perhaps I didn't see well, but I didn't see it. I did see a lot of things, of different groups, but not this one. And I think it could be an interesting group, because we could send our administrative people to this type of information, saying that there has been a work at the European level with a group of parents, saying that even from an economical point of view, it could be very interesting to implement such standard of care.
Mm-hmm. There is also a discussion at the moment on quality management, where we discuss at the moment if there is something what we can implement also as a further group, and also of course the economics, but also the implementation in the end. That is also something where we are working at the moment on this kind of groups, or how can in the groups people work together on this one topic. This is not finalized at the moment, but we also want to put pressure on the implementation. So one key word is certification. So if people or if hospitals are certificated, like baby-friendly hospital, in the future having the standard as a certification model, if you do this, or if you have the standard implemented, then you get the stamp you are a good NICU, then parents will decide in which hospital they want to deliver or they want to have their baby. And this will put pressure in the end on the different hospitals and also on your director. If in the neighborhood is another hospital who has the stamp and is the best one in the standards of care, maybe the people are going there and not in yours. Or hopefully it's the other side.
I'm not sure it fits with the reality, because the reality is that all the units are full and the babies are going where they can go, not where the parents are choosing, That's a fact.
Do you want to come in now?
question.
Lisa. Okay, the mic here. Oh, sorry. Yeah, first Veronique, yeah? Lots of French.
I wonder if it couldn't be interesting to have a survey about the caregiver burnout in the different units, because we all know that it's a reality and we do not know exactly what are the determinants of burnout in the NICU. But I think that it could be very important to understand, also because we have a few qualitative studies now looking, for example, at implementation of kangaroo care, and the thing that comes out is that nurses are challenged ethically because they would like to implement kangaroo care more deeply, but there are lots of barriers. And if we increase the knowledge, of course, it's very important, and it will help to further implement kangaroo developmental care. But on the other hand, we have to be careful to the professionals and not to go too fast or, well, to ignore that that aspect of care, I think.
Just to respond to that a little bit, I think what we have seen in the last few years, because I've been part of APIB and NITCAP in the beginning, and it was very tough to be in a unit where this was trying to be implemented, and the answer from the professionals was always, you have no evidence that this is working. And I think so any way of accepting in the academic world is by doing research that provides the evidence that it is actually making a difference. And I think overall the developmental care active people over the last 10 years have made a big effort to provide this evidence in many studies, and I think that has put us on the medical horizon in the academic environment. And if we continue to be productive and to actually show the effects of the interventions, then we will convince the medical community to make this part of standard education in the medical field.
I would like to share one piece of experience related to hospital design, as we have now a situation where we are in a location where we have single family rooms available for the majority of families, but not to all. And that is a model that creates dissatisfaction. All families in our culture want to have the single family room. And I would discourage anybody to plan units with this mixed model. We have different ways to solve the new challenges which do come along with single family room architecture. And they can be planned so that there are nursing stations and centralized nursing, so that we don't discard teamwork, which is a value and valuable thing in our units. We don't need to have decentralized nursing when we have single family rooms. It just takes planning to get both benefits to your unit. Another challenge is this situation where the parents can't be there with their baby, but I think I would kind of give a challenge now to Silke's group to think with other parents what are the new solutions to this situation. I would rather see new solutions than going backwards and going to open bay structures.
Well, I see the challenge with having only single rooms, as Bubu already said, is there are some situations of families they can't be there. So that means there may be our single moms and have 4 brothers and sisters at home and can't be there all the time. So there is not enough or not a long enough maternity or parental leave. We have in Germany changed the law for this. In a couple of other countries is it done as well, to have a longer maternity leave. But nevertheless, there are maybe long distances between who is caring at home for brothers and sisters, or when there is a single mom who is taking care of making money. And these are challenges in some families where they can't be every day there. That is often a challenge, and this have to be solved as well parallel on a policy level. And especially in the US, as you said yesterday also, that there is no maternity leave at all in the most of these areas. And so that's a challenge. And if you have not the parents who can't be there, then is a single room system maybe not the right, yeah.
I understand the challenge. I'm just asking for new solutions, not going backwards in architecture as a solution.
Yeah, but
I could comment on that.
Yeah.
There are new solutions, Lisa, as you know.
Yeah.
I mean, you can have a combined open bay with a but with the nurses, and as we have designed some of the units, you have the parental part just behind. But what I think is the next step, and what we are doing here, is really to make a step into parental decision within the unit. That is the next step for developmental care, an early intervention program to educate the parents, and also let the parents take the decision with you within the unit from the first 24 hours. I think that would be, because some of the programs we are launching is too complicated even for a neonatologist to learn, and takes too long time. So we need a very sophisticated system like NIDCAP, and we also need some of these more easy systems to learn out, and you have to have both. It's not that you can have one of them. You need, in a really family-centered care unit, you need to have both the very complicated system and an easy educational tool for parents, and also as a doctor and a nurse within the nursing team to give the parents so what we're trying to do is to give the parents the responsibility to give the reports, for example, the parents giving the report to the nurses what happened the last 24 hours and not the other way around, and all of these things. I mean, this would be the next really challenge in neonatology, to just step back and look and let the parents do everything. They can even intubate.
But I mean, like, on your last comment, Bobo, I think we also have to be careful not to burn out the parents. And I think sometimes and I know I've spoken with Dominique about that many times, there are mothers that are overwhelmed by sitting next to their very sick preterm infant in a closed single-parent room with a baby on very high ventilator settings, unable to really interact because too sick, and be there and the nurse is walking out of the room. And that actually, in many ways, imposes a much bigger stress than being in a surrounding where there is social sharing of burden. And I think we have to, for me, the chapter of single parent or single family room and open space social community interaction is not solved yet in an evidence-based manner. And so I think I would encourage you all to research into this question in more detail.
And Petra, that's one of the reasons we really try to do the suite model, so that the parents actually could leave but be close and to relax. And also over 20 years of experience with having parents very present, we also from time to time suggest that they should take a leave and go home and do things. And it's interesting to see that there's such a few parents that actually are burned out. So, I mean, we shouldn't be so afraid, as long as we design the units as we have in Huddinge and at Danderyd, so that you can actually go away for a while and take a break, but be in the proximity. So if the infant becomes worse and needs more stabilization, we can call the parents in and ask for their active care as well. So I think definitely we need to have flexibility both in the guidelines and both in the design of the NICUs. Who?
I just want to make a very fresh comment. Maybe I belong to the new generation of medical doctor,
I was there 10 years ago after my medical study just to join a NIDCAP meeting there. And I just want to thank you because you gave us the vision of what developmental care is. And these past 10 years, you gave us the proof of developmental care. And so I really want to thank you for that.
Linda.
Hi, Linda Frank from San Francisco, and I've really, really enjoyed this day and this very rich panel discussion. You know, it's wonderful to see how the developmental care and the work with families has developed, and I really appreciate that. But as a researcher, I am trained to always look for the gaps, and one of the things that I have not heard mentioned yet in terms of particularly the integration of parents, We've talked about the individual level and involvement of parents and the policy level, and I just haven't heard at the local level talking about parent advisory groups and influencing the policy of individual units or individual hospitals. And I think that has been shown in the work of for example, the parent and family-centered care organizations in the States and in the hospitals in the U.S., where they take the next step and integrate parents into the local policy of a unit or a hospital. That has really addressed a lot of the concerns that have been raised and developed the adaptation to the local context. So, for example, any nursing or medical policy is reviewed for input by families that come from that unit, come from that community, and they have an opportunity to comment, and vice versa. It has that exchange, and so that might address some of the things that you're talking about. And I hadn't heard it mentioned, so I just wanted to raise it.
I just wanted to say something about that because I'm involved as an advisor on a project which is very local and which is it involves parents and staff reviewing their practice and thinking about what's to change. And it's generated enormous enthusiasm on the team and an enormous will to change. And what's so fascinating is absolutely nothing new about it at all. It's all things that, have been researched, which we've discussed, which we're all trying to do. But the fact that it's their unit, it's their ideas, it's their policies, that's what matters. And I think this is, whether it's advisory groups or that, but you need to get to grips with what you and your families want on your unit, and that is, I think, will make a difference to whether people are ready to change or not.
Do you want to comment, Silke, first?
Yeah, I just want to comment that in most of the hospitals I know in Germany, it's not existing, that there really is a parent advisory group who is giving feedback. And I can't remember on it. There are self-help groups who are doing something for the unit, but asking that the doctors and nurses asked for their advice. Not at all in Germany since today. Also not me as now in this position are asking me what's my advice. That's not in most of the countries, I guess, in Europe, not really existing. More in the UK maybe, and it's coming up more and more. But this is typical US. In Germany, no one hospital has an advisory board for parents.
Yes, I could second you on that.
Yeah.
I mean, we have had a lot of parents engaged in our care, but our experience is that when they are discharged, many of them just don't want to get involved so much anymore. But so it could be difficult. But I think we should accept the challenge and see if we can do something structurally, systems-wise, to improve.
It's just a remark. We have been learning that we have to individualize the care for the babies. I'm not asking for individualization of the recommendation, but I think we should be very careful because just the question, for example, in Sweden, 18 months of maternity leave. In France, 3 months. Okay, so I think, to my knowledge, my experience in the clinics is that there is one feeling which is always in the parents is culpability. So I think we have to be very careful, because otherwise, if we say you have to be there all the time long during hospitalization, again, you have to be very careful, because then you will add some culpability on the culpability which is already here, already. So I think we have to be very careful about that. And again, probably the good way is to act on the politicians. So that's for, as you say, probably you said, to act so that the maternity leave for when you have a preterm baby is longer than for the other in other cases. But then otherwise we have to be very careful about that, not to be deleterious by providing such a wide recommendation which are not applicable everywhere.
In Germany we had just 8 weeks after birth, and now we have 12 weeks plus the weeks you lost before. So you have 18 weeks fully paid maternity leave, and then you have parental leave. But you have then the opportunity to be there. Before you wouldn't be there because you have to work again. And so this is what's changed, that there is an opportunity to come. Of course they need some, or I needed also a break, because I couldn't be there all the time. And we had of course no chairs to sit and so on. So that's, but to have the opportunity to feel, and the key thing is to feel welcome. And not feel someone who is not welcome, who is not, you are coming again, oh yeah, come on, sit here or whatever, or you have to wait. Sometimes I wait half an hour outside, I rang, and then nobody was coming. And so these are the things, feeling welcome. And this is, I guess, a different, what we can learn a lot from the Nordic countries. You really come inside and you feel it. It's amazing, as I was there the first time.
Would you like to comment?
I just had a comment. I was invited by Björn to a workshop Friday, and I heard from Humin City, from Malawi, and from Tanzania that they have KMC beds, and they give all of the care to the infant from the beginning. It's not a question of how long your parental leave is. It's just the knowledge that you don't separate babies from the mothers. I mean, that is something we never could argue for. So I would never stand back from a standard that say 24/7 as long as the baby is at the hospital. I mean, that must be, and then we have to argue for it, of course, because there are a lot of politics around it, but we should be able to provide, as neonatologist or I'm a director at the moment, the facility for parents to be with their kids 24/7.
Exactly.
No, Pierre Kuhn from Strasbourg in France. It was just a comment and an answer to the question that Jean-Charles has raised. I think, of course, we have to be pragmatic in a way, and there are differences among countries in Europe, across Europe. I know well the Swedish system now, and I realize the differences between France and Sweden about parental leave and all the organization of the society. But I think we should as an expert panel, as a reference, we should always keep in mind what's the best for the baby. This is patient-centered care and the family. And so this thank you. But I mean, when we are facing problems to implement developmental care from at a political level and all the things, first we should think to the baby and come back to his needs, and after we can try to do our best about that. So it was just a comment.
Good point to end.
Good point to end. Yeah.
Yeah.
You want to say something? Yes, please do.
Well, actually, I just want to say one thing before we bring this to an end. I just wanted to go back to Vilma's point about if you're in a position, you don't have funds, you want to make progress, and you said something about buddies. And I thought, actually, you've given me an idea. I think this could be quite a nice thing to do, to think about people who have different languages, who may be available as a resource, as a kind of mentor or buddy for people in positions like yourself trying to make progress and needing some help. So I think I'm going to do something with that idea. And otherwise, do we need to stop now so we could say thank you to all of you for those very valuable contributions to the discussion, as well as for the fantastic presentations we've had. So I think we've all gone away with some great ideas, and thank you all for coming.